Welcome back to the deep dive. Today we are shifting gears slightly. We are not just exploring a topic for general curiosity, we're on a mission. We're stepping into the shoes of a postgraduate student preparing for a high-stakes assessment. Specifically, we are targeting the Gujarat University MD Anesthesiology exams.
That is right. And if you're listening to this, I want you to imagine you're sitting in the library, notes open, pen in hand.
Okay.
I'm taking on the role of your senior MD faculty today. We're going to tackle a topic that's not just a critical clinical skill, but it's what I call a guaranteed scoring topic.
Ah, one of those.
Exactly. If this comes up in your theory paper or your Viva, you need to know it cold. We're talking about patient-controlled analgesia, or PCA.
Okay, let's unpack this. We've got a stack of heavy hitters for source material today. We're pulling from Miller's Anesthesia, Stolting's Pharmacology,
Morgan and Mikhail, the ARC guidelines.
and we've even got the specific DNB question bank references to see exactly how examiners ask about this.
Precisely. And looking at the history, this is a frequent flyer in exams. We saw it in the DNB papers in December 96, June 98, June 2003. All the way up to December 2014.
So it comes up again and again.
It does. And the questions, they range from these broad, long answer questions like, write the benefits of PCA to very specific practical tasks like write a prescription and set parameters for a morphine PCA.
So this isn't just theory. You might actually have to write out the settings on the exam paper.
Absolutely. You need to know the numbers. You need to know the doses. So our mission today is to give you the structure for a 20-mark long answer, the bullet points for short notes, and the safety net answers for the Viva.
I'm ready. Let's start at the beginning. If I'm writing that exam answer, how do I frame the introduction? What is the definitive definition we should be using?
Okay, good question. You want to start strong with a definition that shows you've read the standard texts. So based on Harrison's and the ARC guidelines, PCA is defined as a method permitting the infusion of a baseline dose of opioid plus self-administered boluses to control pain.
Okay, that's the what.
Right. But here is the key concept you absolutely must add, and this comes straight from Miller. It is a mechanism designed to address individual analgesic requirements.
Individual requirements, that's the why behind it, right? Because everyone reacts to pain medication so differently.
Exactly. That's the whole point. We're trying to circumvent the pharmacokinetic and pharmacodynamic variability between patients. Two patients might have the exact same surgery, but one needs twice as much morphine as the other. PCA solves that problem.
And it solves the problem of the old school PRN method, pro renata, or as needed dosing by the nurse.
Right. And you need to contrast PCA with that older method to show you understand the rationale. Stolting describes the problem with nurse-administered IM or IV injections perfectly. He calls it the peaks and valleys of analgesia.
Peaks and valleys.
Yeah, you give a big shot of morphine, the drug level spikes, and the patient might be overly sedated or even have respiratory depression. That's the peak. Then the drug wears off, the patient is in pain, they have to call the nurse has to sign out the drug, draw it up. I mean, by the time they get the dose, the patient is in agony. That's the valley. PCA just smooths all of that out.
So in an exam, the examiner is looking for that comparison, the peaks and valleys versus the stability of PCA.
Yes. If you get a long answer question, specifically a 20-marker, you start with the definition, you mention the peaks and valleys rationale, and you outline the exam patterns.
Okay.
They might ask for principles, settings, drugs, advantages. Or, as short notes, they love asking about safety features of PCA or PCEA. That's patient-controlled epidural analgesia. We'll get to that.
And Viva, what are they looking for there?
In the Viva, they will absolutely grill you on the lockout interval and PCA by proxy. Those are the classic traps.
Got it. Okay, let's move to section 2. The principles of PCA. You mentioned this is very high yield.
Yeah.
So what is the core scientific principle here?
The core concept. Really, it all relies on small, frequent doses. Stolting explains this beautifully using kinetics. The goal is to keep the drug concentration at the effect site, so the brain and spinal cord, within the therapeutic window.
The therapeutic window.
We call this the MEAC, the minimum effective analgesic concentration.
So instead of a big wave crashing over the wall, it's like small ripples, just keeping the water level steady.
That is a perfect analogy. A fantastic way to put it. You want to maintain the level just above the MEAC, but below the toxicity threshold. But the most critical principle, and if you miss this, you fail the question, is the negative feedback loop.
Here's where it gets really interesting. This is the built-in safety mechanism, right?
It is. This is the elegant part of the whole system. Miller makes a crucial point here. The loop works like this. The patient is in pain. They press the button.
And they get a dose.
They get a dose. The pain is relieved. They stop pressing the button.
Simple enough.
But here is the safety catch. If they press the button too many times, what's the first sign of opioid overdose? Sedation. So if the patient becomes sedated, they cannot press the button.
Ah, so the patient literally falls asleep before they can start breathing.
Exactly. Sedation precedes respiratory depression. That is the intrinsic safety of the system. The loop only fails if someone else interferes.
Someone else.
Which is why PCA by proxy, family members pressing the button for a sleeping patient, is so incredibly dangerous. It breaks that beautiful, simple safety loop.
That makes total sense. And there's a psychological component too, right? I think Wiley's mentions this.
Yes, absolutely. Patient autonomy. This is a huge point. Studies show that even if the actual pain scores are the same between PCA and nurse-administered drugs, PCA patients are consistently happier.
Just from having control.
Just from having control. They aren't helpless. They aren't waiting for someone else to relieve their suffering. That reduction in anxiety is a huge part of the principle.
Okay, so we have the definition and the core principle of the feedback loop. Now let's look at the machine itself. Section 3. Components of a PCA system. What do we need to know about the hardware?
Right. You don't need to be an engineer for the exam. But Kaushik Jothanath outlines the basics you should be able to list. First, the pump itself. You have syringe pumps like the intrafuser or volumetric pumps like an Infusimat.
And then the part the patient uses.
The handset or demand button. That's the patient interface. It's the only part they really interact with.
And there's a computer involved, presumably? It's not just a simple button?
Oh yes, the microprocessor. This is vital for the exam because Miller notes that the computer records data. It records successful attempts versus unsuccessful attempts.
Unsuccessful attempts. You mean when they press the button but don't get drugs because of the lockout?
Exactly. And that data is gold. It tells the doctor if the prescription is working. If a patient presses the button 50 times in an hour but only gets 5 doses, what does that tell you?
They're in a lot of pain and the settings are wrong.
Exactly. Their pain is undertreated. You need to change the settings.
Right. And obviously the drug reservoir, the syringe or the bag, needs to be secure.
Correct. It must be in a locked housing. We are dealing with potent opioids here. Theft or tampering is a real risk. You have to mention that for a complete answer.
Okay, now we are getting into the meat of the exam question. Section 4, PCA parameters and settings. You said earlier they might ask us to write a prescription. What are the numbers we need to memorize?
This is the exam core. This is where you score big marks. You need to know 4 settings: the bolus dose, the lockout interval, the background infusion, and the limits. Let's start with the bolus dose.
Okay.
This is the amount of drug delivered when the button is pressed.
What are the standard starting doses, according to Miller, let's say, for the most common drugs?
For morphine, the gold standard, the bolus is typically 1 milligram.
1 milligram, okay.
For fentanyl, Miller suggests 10 to 20 micrograms. Now, the text does mention 40 micrograms theoretically, but in clinical practice and for your exam, you should stick to the lower, safer end, 10 to 20.
Got it. And hydromorphone?
It's more potent, so the dose is lower. 0.2 to 0.4 milligrams. You should know those 3 cold.
Okay. Morphine 1 milligram, fentanyl 10-20 mics, hydromorphone 0.2-0.4 milligram. Got it. Now the lockout interval, this is the safety net we talked about.
Yes, the definition is crucial. The mandatory time period after a successful bolus during which the pump will not deliver another dose, even if the button is pressed.
And what's the standard time for that?
Both Miller and Stolting recommend 5 to 10 minutes.
Why 5 to 10? Why not 2 minutes? Or why not 20?
This is a classic Viva question. What is the scientific basis for the lockout interval? And the answer is...
the time to peak effect.
Exactly. The interval must correspond to the time to peak effect, the T-peak of the drug. If morphine takes about 7 minutes to reach its peak effects in the brain, but you set the lockout to 3 minutes, what happens?
Your patient will press the button, feel nothing yet, and press it again.
Right. And by the time that first dose actually hits, they've already stacked 2 more doses on top of it. That is how overdose happens.
Dose stacking. That makes perfect sense. So the lockout prevents the patient from getting ahead of the drug's onset. Now, what about the background or basal infusion? This seems controversial.
This is an exam trap, a big one. A basal infusion is a continuous trickle of drug given regardless of demand. The trap question is, should you use a basal infusion for a routine post-op adult?
And the safe answer is?
No. Miller is very, very clear on this. In opioid-naive adults, basal infusions increase the risk of respiratory depression without significantly improving analgesia or sleep.
Why?
because it disrupts that beautiful negative feedback loop we talked about. The drug keeps going in even if the patient is already sedated.
So when do we use it? Are there any indications?
Yes, but they're specific. Opioid-tolerant patients. So chronic pain patients who have a high baseline requirement, they can benefit. Or sometimes in pediatrics, which is often called nurse-controlled analgesia. But for your standard exam answer, approach basal infusion with extreme caution. Always mention the increased risk.
Okay. And finally, the hour limits.
Right, this is the hard ceiling. The pump can be programmed to limit the total volume delivered in, say, 1 hour or 4 hours.
Yeah.
Morgan mentions a 1-hour limit of roughly 15-25 millimol for epidural PCA, for example. It's just a final fail-safe against machine error or, I suppose, extreme patient error.
Okay, we've set the machine, now let's load it. Section 5. Drugs used in PCA. You mentioned morphine and fentanyl. Let's dive a little deeper into those.
Absolutely. This is another very high-yield area. Morphine is the reference standard, the drug all others are compared to. Stolting gives the regimen a 1 to 2 milligram bolus with a 6 to 10 minute lockout.
Okay.
But you must mention the metabolites. Morphine breaks down into M3G and M6G. N6G is active, and it can accumulate in patients with renal failure, causing profound toxicity.
So if the patient has kidney issues, maybe skip the morphine.
Exactly. That's a key clinical decision point. In that case, fentanyl is a much better choice.
Why fentanyl?
It has a rapid onset, a short duration, it's great for hemodynamic stability, and crucially, it has no active metabolites. Stolting suggests a 20 to 50 microgram bolus with a 5 to 10 minute lockout. It doesn't rely on the kidneys for clearance in the same way.
What about hydromorphone? You mentioned it earlier.
Yes, it's a good alternative for patients who are intolerant to morphine. Maybe they get severe itching or nausea. It's stronger, so the dose is lower, 0.2 to 0.4 milligram bolus.
And I see remifentanil on the list. That's the ultra-short-acting one, right? Very potent.
Yes, very. Miller mentions it specifically for labor analgesia in women who can't have an epidural. Because it's metabolized by plasma excreces, it's gone in minutes. But because it's so potent and fast, it requires extremely careful monitoring. We're talking one-to-one nursing usually.
Any adjuvants? Can we mix other things into the PCA?
You can. It's becoming more common. Miller notes that adding ketamine to a morphine PCA can improve analgesia, particularly in big cases like thoracic surgery. It has an opioid-sparing effect. You might also add antiemetics to handle nausea.
Okay, great. Moving on to Section 6, routes of PCA. We usually think of IV, but there are others.
IV PCA is definitely the standard. It's the most common. But PCEA, patient-controlled epidural analgesia, is a favorite topic for short notes in the exam.
Right. So how does it differ from a standard epidural?
Well, you're delivering a mixture of local anesthetic and opioids directly into the epidural space. Kaushik-Jofaneth lists the typical regimen. Usually a low concentration of bupivacaine, like 0.0625% or 0.125%, mixed with fentanyl, maybe 2 to 5 mics per ml.
And is it better than IV PCA?
In terms of pure pain relief, yes. Miller cites the Salicath review, which says PCEA provides superior analgesia compared to IV PCA, but the clinical difference might be modest for some surgeries.
So what's the big advantage?
The big advantage, also according to Miller, is that you get reduced motor block compared to a continuous epidural infusion. The patient is only taking what they need for pain, not numbness, so they can move their legs better, which is great for recovery.
There are also mentions of subcutaneous and intranasal routes in the ARC guidelines, but let's stick to the main ones for the exam. What about indications? Section 7. When do we use this?
Think in broad categories for your answer. Surgical is the obvious one, major post-op pain from a thoracotomy, a laparotomy, big orthopedic cases.
And trauma.
Trauma was a big one, especially rib fractures. ARC mentions this specifically, and it's a great example. If a patient with rib fractures hurts too much to take a deep breath, they get pneumonia. PCA allows them to control the pain well enough to maintain their respiratory mechanics.
Any medical indications?
Yes. Acute pancreatitis ARC mentions this sickle cell crisis, which is incredibly painful, and severe mucositis from chemotherapy.
And what about pediatrics?
This often surprises people. Miller states children as young as 4 or 5 years old can effectively use PCA.
Really?
Yes, provided they have normal cognition, and you explain it to them very, very well before the surgery.
That leads us perfectly into Section 8, contraindications and patient selection. When do we say no to PCA?
The absolute contraindications are crucial for the exam. Right. First, inability to understand the concept. If the patient is confused, demented, or delirious, they cannot use that negative feedback loop. It's unsafe.
Okay, that makes sense.
Second, a physical inability. ARC points out severe arthritis or paralysis. If they literally cannot press the button, the system is useless.
And patient refusal, obviously.
Correct. Then you have relative contraindications.
Yeah.
The main one is severe respiratory compromise, like untreated obstructive sleep apnea. You can use PCA, but you must be extremely careful. Absolutely no basal infusion, maybe longer lockouts, and continuous monitoring with pulse oximetry or capnography.
The ARC guidelines really emphasize preoperative education here.
And that's a brilliant exam point to make. You cannot teach a patient how to use a PCA when they are waking up groggy and in pain in the recovery room.
You have to do it beforehand.
You must educate them preoperatively. They need to understand the simple concept. Push the button when it hurts. Don't wait for the pain to get out of control.
Okay. Section 9. Advantages of PCA. This is an exam favorite. Why is it better? What are the key points to list?
For your answer, you should group this into clear headings. First, pharmacokinetic. As Stolting showed, it eliminates the peaks and valleys. You get stable plasma levels.
Right.
Second, psychological. Higher patient satisfaction due to that sense of autonomy we discussed.
Yeah.
Miller backs this up.
Third.
Nursing. It leads to a reduced workload. ARC notes there's less time spent drawing up and administering frequent injections.
Which frees them up for other monitoring.
Exactly. And fourth, respiratory. Wiley notes better respiratory function compared to conventional opioids because the patient is less sedated overall, so they can cough and take deep breaths more effectively.
It sounds perfect, but of course nothing is perfect. Section 10, complications and side effects. This is marked as very high yield.
It is. The big one, the one that everyone fears, is respiratory depression. The incidence is about 1.5% according to Miller, so it's not common, but it's serious. The risk factors are key to know for the exam.
And those
Using a basal infusion, advanced age, obesity or sleep apnea, and the concurrent use of other sedatives, especially benzodiazepines.
Then there are the standard opioid side effects, I assume.
Yes, nausea and vomiting, PONV. Interestingly, Miller notes there's no significant difference in PONV rates between PCA and PRN opioids. Opioids cause nausea regardless of how you give them, and pruritus itching is very common with morphine.
What about equipment failure or human error?
Programming errors are a huge issue, setting milligrams instead of micrograms, for example, a 10-fold or 1,000-fold error. But there's also a physics concept called siphonage.
Siphonage.
Yes. If the pump is placed high above the patient, say on a tall IV pole, without a proper anti-siphon valve, gravity can literally pull the drug out of the syringe, causing a free-flow overdose.
Wow. Okay, and we have to mention PCA by proxy again here.
We have to. Miller explicitly warns about this. It's the well-meaning family member who sees the patient asleep and moaning slightly, so they press the button for them.
Bypassing the whole safety mechanism.
Completely bypassing the sedation warning sign and pushing the patient directly into respiratory arrest. It is the single most dangerous practice associated with PCA.
That is terrifying. So how do we keep them safe? Section 11, monitoring and safety. What do you need to do?
Miller Box 77.1 lays it out perfectly for an exam answer. You need standard vitals, respiratory rate, pain score, at rest and on movement, and the total dose delivered from the pump's history.
Okay.
But the single most important parameter you must monitor is the sedation score.
Why is that more important than just counting the respiratory rate?
Because, as we've said a few times now, sedation precedes respiratory depression. If the patient is becoming drowsy and difficult to wake up, that is your earliest warning sign to stop the pump and reassess. A patient can have a respiratory rate of 12 but be completely unrousable.
That's a critical point. And regarding the hardware safety?
One-way valves. Kaushik Jathanath emphasizes this. You must have a one-way or anti-reflux valve in the IV line.
Why is that so important?
Without it, the opioid from the PCA could flow backwards, up the IV tubing into the main saline bag. It could accumulate there, and then if a nurse suddenly flushes the line, the patient gets a massive bolus of opioid all at once.
I see. Okay. Section 12, comparison with other methods if you get a compare and contrast question in the exam.
Right. So PCA versus IM opioids. That's easy. PCA has a faster onset, gives a steady state, higher patient satisfaction. IM is painful, has variable absorption, and you get that peak and valley effect ARC talks about.
Okay. What about PCA versus an neuraxial, like an epidural?
Epidural is generally superior for dynamic pain on coughing and moving, especially after major thoracic or abdominal surgery.
But
PCA is much easier to set up, it's less invasive, and it has no risk of epidural hematoma or abscess. The trade-off is that the systemic side effects, like sedation and ileus, are higher with IV PCA. That's a point from both Miller and Morgan.
And finally, PCA versus a continuous opioid infusion.
The continuous infusion is dangerous. because it completely lacks the feedback loop. It just keeps pumping, risking accumulation and overdose. PCA is inherently safer because the patient self-titrates to effect.
Okay, we are in the home stretch. Section 13, common exam questions and Viva traps. I'm going to throw some questions at you. You give me the safe, examiner-approved answer.
Let's do it.
Question 1. Can I use a basal infusion for a 30-year-old, otherwise healthy post-laparotomy patient?
Answer: no, or at least generally no. You would state that according to Miller, it increases the risk of respiratory depression without proven benefit in opioid-naive patients. The safest approach is demand-only PCA.
Okay. Question 2. What is the ideal lockout interval?
Answer: the ideal lockout interval is not a fixed number. It depends on the drug's circulation time and its time to peak effect. For IV morphine or fentanyl, 5 to 10 minutes is a standard starting point. Setting it shorter than the drug's onset time is dangerous as it encourages dose stacking.
Perfect. Question 3. My patient is still in pain despite pressing the button frequently. What could be wrong?
This is a great troubleshooting question. Your answer should be systematic. First, check the mechanics. Is the IV patent? Is it tissued? Then check the settings. Is the lockout interval too long? Is the bolus dose too small? Finally, consider the patient. Is their pain truly that severe? Or are they perhaps seeking sedation rather than analgesia? Wiley mentioned pseudo-addiction, where patients appear drug-seeking simply because their pain is undertreated.
Last one. Question 4. Compare PCA and continuous epidural infusion, or CEI.
Answer: according to Morgan and Mikhail, PCEA generally uses a lower total dose of local anesthetic and opioid, and as a result, it causes less motor block and less sensory numbness than a continuous epidural infusion.
Fantastic. Now, Section 14. Diagrams and exam presentation. If I have a blank sheet of paper in front of me, what am I drawing to impress the examiner?
2 things will get you maximum marks. First, the graph from Stolting, figure 7.25. It's simple but powerful. Draw a y-axis for plasma concentration and an x-axis for time. Then draw 2 horizontal lines to create a therapeutic window and label the bottom one MEAC. Then you draw a jagged sawtooth line that swings way above and way below that window labeled at IM dosing.
And for PCA?
You draw a small, tight ripple line that stays neatly within the window, labeled at PCA. It visually explains the entire concept in seconds.
Visualizing that really helps. And the second diagram?
A simple pump schematic, a block diagram. Draw a box for the reservoir, an arrow to a box for the pump mechanism, then an arrow through a one-way valve into a Y connector, and then to the patient. And critically, draw another line from a demand button going to the microprocessor which controls the pump. It shows you understand all the components and their relationships.
And structuring the long answer itself.
Start with the definition. Draw that graph immediately. Examiners love a good graph. Then use clear headings, indications, settings, and maybe draw a small table for morphine and fentanyl doses. Then advantages and complications. Always conclude with a strong section on safety.
Which brings us to our final section, number 15. Summary and exam conclusion. Give us a recap. The high-yield bullet points.
Okay. Here are your take-home points for the exam.
PCA's safety relies on the negative feedback loop, where sedation prevents overdose.
The key settings are the bolus dose, the lockout interval for safety, and the basal infusion, which should be avoided in naive patients.
The drug choice is typically morphine, the standard, or fentanyl for patients with renal issues or hemodynamic instability.
The lockout interval must be long enough to allow for the drug's time to peak effect to prevent dose stacking.
When monitoring, the sedation score is more important than the respiratory rate as an early warning sign.
The most dangerous complication is respiratory depression, and its biggest human error cause is PCA by proxy.
Perfect. And if we need a professional, concise closing statement to wrap up the essay?
You write this, or something very close to it. PCA represents a paradigm shift from paternalistic dosing to patient autonomy, offering superior pharmacokinetic stability and patient satisfaction, provided that patient selection is appropriate, and safety parameters, specifically the lockout interval, are strictly observed.
That sounds like a 20-mark answer to me.
It definitely is. And to the student listening to this, visualize that pump, visualize the graph. Remember that safety is your #1 priority for the examiner. Good luck with the Gujarat University exams. You've got this.
Thanks for that masterclass. And we'll see you on the next deep dive.